fascinating ideas and actual clinical treatment that you used on amputees to improve their quality of life. And hopefully in the future, I think we can maybe combine our technologies into, well, Terminator 99 or whatever. So please, Todd.
Well, thank you. Thank you, Ricard, for having me today. Thank you all for coming. So I'm a physiatrist, a rehab doc, who focuses on taking care of people with amputations and doing research. And I must say, most of my time in clinic is spent on socket issues. Ricard was too nice because sockets really are the biggest challenge we face, and I'm very excited about osseointegration as a superior suspension system. However, my research is on a complementary area of steering. You got suspension, I'm steering. So we're going to talk today about how we might improve the control of robotic limbs. I need not tell this audience about how poor the state of the art is. The most common device is still a body-powered prosthesis where you can control pretty much just one thing at a time using a cable and shoulder movements. The state-of-the-art myoelectric prostheses, we can build very dexterous robots, but how do you tell them what to do? Again, only 1 degree of freedom at a time, and it's generally not very intuitive once you get above the elbow because you're using muscles that don't relate to function. So we need a neural interface to acquire more motor control data and hopefully give back some sensory information. Our options include direct peripheral nerve recording, which has been tried for many, many years, and there's been really exciting results out of Sweden in this area recently. Perhaps brain-machine interfacing. It's an exciting area of science and may be useful in, I think, spinal cord injury before we see it in amputee. And then we've developed a technique which is kind of a workaround technique called targeted reinnervation. The idea is that when you have an amputation, you still have your peripheral nerves that contain all the motor control data we need, as well as the sensory afferents. But how do you express it? We need an amplifier to get those signals out because it's really hard to record from the nerve. So what we've done is taken the major peripheral nerves and we transfer them to spare muscles in an amputee. So for example, in a shoulder disarticulation amputee, imagine denervating the pectoralis muscle and taking the brachial plexus nerve to separate sections of that muscle. The muscle then serves simply as a biological amplifier. You think closed hand, median nerve function, one section of your chest contracts, and we use the old-fashioned myoelectric technology to record that. You think bend your elbow, muscocutaneous nerve, a different section contracts, and so we can get at least 4 control signals by just using the 4 major nerves. This allows for intuitive control because you're using the nerves in the way they were intended. We can control both a hand and an elbow simultaneously, and we do it without, so far, implanting any hardware into people. It does require additional surgery, though. So this is the first gentleman we did it on, Jesse Sullivan, saint of a man who lost his arms in a high-power line accident. He had these split-thickness skin grafts that required revision because they were painful, so we went and we rewired him. This was the essential surgical design done by my colleague Greg DeManian, where we divided the pec based on its neurovascular anatomy into 3 sections, took the pec minor out to the side and put the nerves onto these 3 muscles. This is the picture in the OR where we've segmented the muscle sections. To be honest, in those days we were doing it because we wanted to be sure the nerves wouldn't cross over, and we created a scar between them. We don't do that as much anymore because the nerves are really pretty focal and we just don't have the need. It is not a microscope case. We're taking a big fat nerve the size of a pencil, cutting it off, and just sewing it over the motor point of the previous muscle. This is not a fancy nerve-to-nerve coaptation, at least in Greg's OR. And then we also remove as much subcutaneous fat as we can so we can get our electrodes as close to that biological amplifier, as close to the muscle as possible. So we essentially gave Jesse a mastectomy. And this is what it looks like.
Relax.
Jesse is thinking close hand, open hand.
relax, close, relax, elbow up.
He's thinking bend elbow
Relax,
and straighten
elbow
elbow.
down.
And you can
Relax,
see the different
elbow
areas on his chest.
Relax.
Now you might wonder, how'd you get the hand open signal out of him? Well, it turns out by luck, his median nerve, his thumb adductors, reinnervated a separate section of muscle than his finger flexors. So we were able to get both signals in him. This is the arm we've been working with from LTI. Ottobock has now come out with an arm that works for TMR as well. And this is what it looks like. Here is Jesse with his conventional prosthesis, body powered on the right, motorized on the left. He'd used this one for about 2 years, and he's got switch control primarily. Here he's using just 3 of those 4 signals, and you can see that he's much more fluid. It's much more natural control, and he's about 4 times as fast in this little box and blocks test. From the patient perspective, I think the most telling thing Jesse ever said is, "Doc, now I don't have to think about it so much anymore. I can do it." So I'm not saying this is still, that there's no cognitive burden here, but it's a lot easier than hitting switches or thinking about contracting your chest muscle and your back muscle to make your hand, wrist, and elbow move. Then we had a surprise with Jesse. His hand afferents grew into his chest skin. So when you touch him on his chest, he feels his missing hand. And with surprising dexterity, he can feel down to 1 gram of force. He has normal thermal thresholds, normal vibration, all felt in his hand. In many places, he feels both his hand and his chest at the same time, and he can attend to either. So what's happened here is we've taken this mass of nerves and reinnervated his skin, his chest skin, with hand nerves. So, and you can really tell where the nerves were placed. That's the median nerve, which was about there. Here's the ulnar nerve, which was out to the side. The back of the hand was the radial, and a little bit of musculocutaneous nerve up there. So this was a surprise, but a very exciting one. Our hope is to put sensors in the prosthesis that do something at least as simple as give you pressure and feed that back to the reinnervated skin so that when a patient touches something, they feel as if it's their own limb, their own hand, and perhaps get useful information such as goal confirmation or how hard they're squeezing. Personally, I think the psychological effect of having it feel like your hand will likely be the most compelling. Our original goal was really with transhumeral amputees, and this is the more common surgery. We basically take the biceps, divide it in half, put the median nerve to one side and leave the other alone. And in the triceps, we take the lateral head and put the distal radial nerve there. This is a much simpler surgery. It's really straightforward anatomy. Here you can see the median nerve, the 2 branches to the biceps. We just snip one, tuck that one away so it doesn't reinnervate its own muscle, and then it's an easy transfer to go from the median over here. If you have a long enough residual limb, we then take the ulnar nerve, which is just down below this, and attach it to the distal musculocutaneous so that it reinnervates the brachialis. Also, rather than just throw away the fat, we've learned to use it as a separator of muscle signals. So what we now do is make a big muscle fat flap and then tuck it down between the muscles. So here you can see we've separated the heads of the biceps by quite a bit, as well as thinned out the fat overlying the muscle. This is extremely important in helping the prosthetist. These are doable fits, but they're not easy because you have electrodes pretty close to each other. By putting that fat down between, you get better electrode separation, better signal separation. And then this is the first, one of the first patients we did as a transhumeral amputee. Here you see him using the same arm. This one he'd had about 8 months, and it's kind of clever to use his hand this way because it just goes around and around in circles, and it's an easy way to pick up blocks. Here, after 2 months of using this device, he doesn't really feel the need, and he's about 5 or 6 times as fast in this little task. To date, we've done about 40 procedures around the world. Surgically, there's about a 96–97% success rate of being able to have the nerve connect to the muscle and give us a usable signal. We've had really good outcomes in terms of function. our biggest challenges is still the socket, getting that prosthesis on the same way so the electrodes are in the right spot and stay there. So combining this with osseointegration would be a very exciting idea. Now, if you think about it, we're only trying to provide, we only have 3 degrees of freedom in a robotic arm today, a prosthetic arm. Hand open, close, wrist rotation, and elbow. Okay, that's it. And we can't even control those 3 very well. So when you look at all we can do, we can have finger control, wrist control, elbow, and so forth. We're now trying to get more information out of our biological amplifier. So in this experiment, we just saturated Jesse's chest with electrodes, about 100 of them, and had him do 29 different motions, you know, using just his thumb, doing different hand grasp patterns. And here you see, this is just the amplitude of the EMG signal. And you can see these patterns are different, but it's not like I can put an electrode somewhere and say, that's your thumb. It doesn't work that way. So what we've done is collaborated with colleagues in University of New Brunswick, Canada, and using their signal processing algorithms that are really similar to voice recognition algorithms, we have been able to distinguish with 95% accuracy between these very large number of movements, 29, 16. We've also cut it down from 100 electrodes to about 8 to 10. And here you see Jesse using myoelectric control of his elbow, a 2 degree of freedom wrist, a hand that'll do 2 different hand grasp patterns, and his humeral rotator. Okay, he's thinking about each of these functions. It is sequential because we can only do one thing at a time with this voice recognition technology, but it is what we call seamlessly sequential in that it's intuitive. He still has to do one thing after another, however. It's not easy. He makes it look easy, but at least we've given him the levers to control what is here a 7 degree of freedom robotic arm. It has a powered shoulder that he's also controlling with a switch system we developed. So if you have enough money and you make a really fancy arm like the US military can do, this is one made by the DECA Research Corporation. Can you turn the sound off? This has a 2 degree of freedom shoulder, humeral rotator, elbow, wrist, and now the fingers have control of the thumb, first finger, and these 3. So what we can do is make different hand grasp patterns. Now Jesse can't control his individual digits with our technology, but what he can do is when we have him open his hand, he can pick a hand grasp pattern. One of, so far, about 4 or 5 different hand grasp patterns. So he thinks fine pinch, and he goes and he'll be in a fine pinch control mode. If he opens his hand all the way up again and he thinks power grasp, we can go into that mode and then give him different tools to work with. So this has been a very exciting time. But if you think about it, most of our amputees are below our lower limb. And my work has not been relevant to lower limb because we don't have robotic lower limbs until recently. They're all passive devices. Well, now they're starting to come out with robotic legs, and we've taken a shot at implementing this technology with the leg. And here you can see some of the accuracies of trying just to recognize 7 different motions or movements using the pattern recognition technology. And we're up there in the 80s to 90%. Not good enough for controlling a leg yet, but that's just using EMG. So we're excited to be collaborating with colleagues at Vanderbilt and MIT who have now developed motorized legs, a transfemoral and a transtibial prosthesis. And they have lots of onboard sensors that we hope to use in an information fusion to be able to provide good steering to legs as well as arms. And once again, it'll be really nice if these legs are glued on well with osseointegration rather than these crazy sockets I have to deal with. So anyhow, thank you very much for your attention today.